Hello, everyone. Welcome. We'll just take a minute here and let everyone join. Thanks for being with us tonight. We've got 100 and something registered, so I think it should be a pretty big night for us here. So feel free to pop in the chat where you are zooming in from, what your role is in long-term care. Let us know where you're calling from. And we'll just take a minute here and let people trickle in slowly. We're about a minute early, just super organized. Hi, John. Welcome. Hi, Rick. Welcome. Thanks for being here. It's nice to see that we're getting some physicians from Up Island coming. That's very cool. Hi, Dara. Welcome. All right, we'll give it another minute here, and then I'll just do a brief intro, and then we'll get started.
Hi, April. Ralph Jones here from Chilliwack.
Hello, everybody.
Hey, Ralph. Welcome. Okay, so we'll get started. So, welcome to our Victoria South Island LTCI Learning Series event on deprescribing and appropriate use of antipsychotics in long-term care. So, like I said before, please feel free to introduce yourself in the chat. My name is Jessica. I'm the Victoria South Island LTCI Program Manager. So, I'd like to take a moment to welcome you to our Learning Series event this month. It is with great respect and appreciation that I'm speaking to you today from the traditional and ancestral territories of the Sauk Nation, where I'm very lucky to work and live. So just a couple of housekeeping items quickly before we get going. Please keep yourself muted as background noise can amplify very quickly. If you have questions throughout the evening, please pop them into the chat or save them for the Q&A session at the end. There are CME credits available for this. A member of the LTCI team will email you a certificate within the week for your records. At the end of the evening, we will have an evaluation, so please take a few moments to participate. Your feedback is really important to us and helps shape these events going forward. So last but obviously not least, I would like to introduce our presenters for this evening. First, we have Dr. Bryan Chow. Bryan is a geriatric psychiatrist with an interest in quality improvement, particularly in the care of the elderly. He completed his MD and psychiatry residency at the University of BC. During his training, he also completed fellowships in addiction medicine and then in geriatric psych before beginning practice in Vancouver. He is currently working as a geriatric psychiatrist at the UBC Hospital Short-Term Assessment and Treatment Center with the Vancouver General Hospital, geriatric psychiatry consultation liaison, and electroconvulsive therapy services. He also works in the community and at long-term care centers in Vancouver with the Canby Older Adult Mental Health Team. Bryan has recently completed a quality improvement project on improving the disposition planning process for complex patients at the VGH Acute Care for Elderly Unit. Through this fellowship, he hopes to continue working towards improving system-level care for geriatric patients in our hospitals and our communities. So next up, we have April Price. So April has been with Health Quality BC since 2019 in the role of Health System Improvement Leader. Previously, she has worked at Northern Health in a variety of roles that have included quality processes, improvement, facilitation, mentorship, coaching, and executive leadership. April holds a Master of Arts in Leadership with a Health specialization from Royal Roads University and a Bachelor of Commerce from UNBC. She is a graduate of HQBC's Quality Academy and has her Lean Green Belt. April has led quality improvement coaching and program development, supporting BC long-term care homes in a variety of initiatives, most recently focusing on the appropriate use of antipsychotics. April is passionate about seniors care and using data-informed quality improvement and facilitation to foster person-centered care in our long-term care sector. So without further ado, I'll hand that over to our presenters for this evening. Thanks so much for being with us tonight.
Thanks, Jessica. That was an amazing intro. I'll just flip through the intro slide. We're super, super excited to be here tonight with everybody. Thank you so much for giving us the time and having us chat about appropriate use of antipsychotics. I would want to acknowledge as well that Health Quality BC does work throughout the province, and I'd like to acknowledge that we're living and working with humility and respect on their traditional territories of the First Nations peoples of BC. And I do also want to take the time to specifically acknowledge and express gratitude to the keepers of the lands of the ancestral and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Nations, where our main office is located in Vancouver. And I believe that is where Bryan's at today. I don't think you've moved too far since this morning when we met. And then I'm also super blessed to be joining you today from the traditional and ancestral territory of the Sioux people, the Okanagan Nation, which is now known as Vernon. Thanks again, Jessica, for the amazing intros. And so we just have a couple disclosure slides, slide around how we're mitigating potential bias. I will be taking up very little of your time today because I want to make sure that Bryan has lots of time to go over everything around the work that he's been doing. But we would love to just start off by sharing a little background and information on Health Quality BC, our involvement with this area of care since 2013, and then the role that HQBC has played in supporting the appropriate use of antipsychotics in long-term care. But of course, like I said, the bulk of our presentation will be with Dr. Chow leading us through the objectives 3, 4, and 5. And then, as Jessica mentioned, we'll have time at the end for Q&A. So as I mentioned, and Jessica has introduced us, we're with Health Quality BC. And for those of you who don't know about our organization, we are a team of about 35 people. We're located throughout BC and working across a continuum of care. Our purpose really is to improve healthcare quality across BC, and we are uniquely positioned to build those strong partnerships with patients and communities and care providers and health leaders, policymakers, senior executives, academics, and many more. And these connections just really enable us to nurture those networks, recognize the needs of BC's healthcare system, and then build capacity where it's needed the most to just accelerate action on key quality of care issues. We also provide advice and make recommendations to the health system, including the Minister of Health, on any matters related to quality of care across the province. This is just a little snapshot of, as you can see over the years, that Health Quality BC has been involved in quite a few different initiatives supporting long-term care homes in BC. A lot of this support has had a focus on appropriate use of antipsychotics. So we ran 3 waves of the CLEAR initiative before my days, which stood for the Call for Less Antipsychotics in Residential Care, which some of you probably participated in or are very familiar with. This was from October 2013 until May 2019. Then, of course, as we all know, the pandemic hit. We know that it impacted the long-term care sector very greatly. And in the fall of 2020, HQBC partnered with a national organization called Healthcare Excellence Canada, which some of you may be familiar with as well. And from there, we've run 3 iterations of different programming, offering seed funding, shared learning opportunities, and coaching supports to any BC participating care homes. So HQBC's primary role has just been to help with program development, provide coaching supports for the BC homes who participate in the programs. And it was in the 3rd iteration of the program in 2023. It was called Reimagining Long-Term Care. HQBC took an opportunity with that partnership and the program to just refocus our efforts on one area of care, and that was the appropriate use of antipsychotics, as we did see the rates increase, of course, once the pandemic hit. And we know there are a number of reasons for that, but the good news is we made some great progress in our province, and during this program, we also had some really great learnings, seeing really great pockets of work happening across the province, but a lot of times in silos. So we really wanted to build on those learnings, momentum, and as well really look at what system level changes are needed to support the sustainability of the efforts that we do see. So once Reimagining Long-Term Care concluded, we started working on a new toolkit to support AUA And the big focus of the toolkit was to offer some tools and resources for that sustainable approach while we're working really closely with provincial partners, embedding sustainable practices across the province that homes can use well past participating in any sort of program or initiative. So the new online toolkit that we have contains an AUA and long-term care self-assessment tool, which is supplemented with resources and templates. It's what we've been sharing and socializing in this last AUA and long-term care action series that we ran from January to September 2025. Dr. Chow will share later the presentation, one of the tools that he developed, and we're going to be adding this to the toolkit. And we've launched a second cohort of the AUA and long-term care action series. It's an even more focused and structured 6-month learning program starting in January 2026. So we're super excited to be continuing to focus on AUA in the province. It has been so impactful to be working with all the different provincial partners and care homes directly, and we're happy to be sharing this topic with a physician audience as well. We know physician engagement is a huge component to successful AUA practices. So thank you for allowing me those few minutes to share our efforts at HQBC, and I'm going to turn it over to Bryan for the remainder of the presentation.
Thanks, April, and thanks, Jessica, for the introduction. I'm just gonna take over the screen share. Okay, I think that looks right. So we'll review a few additional learning objectives for today. So we want to talk about the clinical use of antipsychotics in dementia. We also want to talk about some of the health policies around antipsychotic use in long-term care, particularly in BC. And go over the quality improvement approach to reducing inappropriate use of antipsychotics. We'll start with a case example. It's kind of a fictional but probably relatable case. So we've got Mr. Lee. He's a 78-year-old male. He's Cantonese speaking only. He's got a history of frailty, cognitive decline, and he recently moved into long-term care from his home where he was living alone. And since he's been at long-term care, the staff have noted that he's been restless, he's calling out at night, and he's not sleeping very well. Probably a common situation that we run into working in long-term care. So we've got this term BPSD. We kind of throw it around there. What does it stand for? Well, it stands for behavioral and psychological symptoms in dementia. It's actually not a term we strictly use in the DSM. We call it really behavioral disturbance. So a major neurocognitive disorder with behavioral disturbance, but those are kind of essentially same terms. You also hear terms used like neuropsychiatric symptoms of dementia. We use this term BPSD, but really it's not one thing. It's not one symptom. In fact, it's kind of a grab bag. There's lots of different symptoms that we include under BPSD. So it basically includes all the non-cognitive symptoms of dementia. Things like mood, anxiety, sleep disturbance, but also things like psychosis, agitation, aggression, sexually disinhibited behavior, wandering, hoarding, calling out. It's basically, there's a lot of different things. So when you say, oh, someone has BPSD, it's really worthwhile to clarify what are we talking about exactly. And often, as a geriatric psychiatrist, we get consulted for, hey, this patient's got BPSD. So what's the approach? Well, the first thing is to clarify the diagnosis. And when I say diagnosis, I mean beyond just dementia. What type of dementia is present? Is this Alzheimer's? Is this vascular dementia? Or is it something with more behavioral symptoms like Lewy body dementia or Parkinson's disease dementia? And there's, other types of dementia. And understanding the type of dementia is really helpful because there are certain patterns of behavioral symptoms that can arise and kind of guides us as to what we may expect and what treatments may be most effective. The second question that I think about is what psychiatric comorbidities are present in the sense that does this person have a pre-existing psychiatric disorder like dementia, like depression, anxiety, or some more severe persistent mental illness such as schizophrenia, schizoaffective disorder, or bipolar disorder. And then the other thing to also think about is beyond those, we call them Axis 1 disorders, are there any pre-existing personality disorders or personality traits that may influence how they kind of cope with distress or how they interact interpersonally? Second thing that I think about when approaching a case of BPSD is characterizing the behavior. So there are lots of different models um, and frameworks to approach different behaviors and how to think about them. The simple way for me I think about is, has there been anything recently that's changed? Whether it's in their social situation, medically, um, what are the risks at hand in the sense that, are there risks to others? Are they trying to hurt someone? Are they, targeting someone? Are they trying to hurt themselves? Are they hurting staff? Those are some of the risks that I think about. And what do they need? Is there anything that they're actually looking for underneath the behavior? Are they looking for companionship? Are they looking for relief of pain? Are they hungry? Are they bored? Trying to think about what they need. A common framework that you'll probably run into or you'll hear about is called pieces, and this is probably one that I find to be quite applicable and easy to understand. And basically, the each letter in pieces stands for a different word. So um, basically helps us generate a differential diagnosis for the cause of behavior. So under physical, you have things like, are they going through a delirium? Is there underlying worsening of a medical condition? Are drugs contributing? Are they having discomfort? Is there a new disability or underlying disability such as like hearing or visual impairment? Intellectual kind of includes things like their forgetfulness. Are they having trouble with communication due to aphasia? Is there apathy at play? Are they having trouble recognizing things or doing things due to agnosia or apraxia? Are they having, perceptual disturbances such as hallucinations? Emotional includes things like mood, anxiety, adjustment. They loop in delusions, personality traits, capabilities, such as, are they having difficulties performing functional things? Environment is something that we don't we may not think about right away because we're so used to the environment we work in, but things such as, was their routine disturbed? How noisy is the kind of long-term care center at that time? Is lighting kind of inappropriate? Or have they just been changed? Have they been moved from their usual position or room? Are things overstimulating, understimulating? And then social is thinking about, who's visiting them. Do they have a social network? Do they have a social network within the long-term care center? What's their life story like? It can kind of inform us as to what things they may enjoy and may not enjoy, similar to their cultural heritage. I mean, there's a lot of items, obviously, under this category, under this pieces framework, and obviously, as cases become more challenging, it kind of helps to go into more and more detail. It helps kind of brainstorm ideas or potential solutions to the situation. So going back to the case example, so Mr. Lee, so we kind of ask a bit more, trying to characterize the behavior. So the staff say that they note that while he's awake at night, he looks like he's responding to internal stimuli, and that's why he's calling out. He looks scared when he's calling out. And even when he is asleep, he's looking like he's talking in his sleep, he's moving around. And when he is awake and moving, they observe a bit of a shuffling gait. They notice that he's more tremulous. The staff are trying to provide some reassurance or distract him with other things, but this only seems to partially help, and he's still not fully kind of calmed. Um, so we think, well, what's the diagnosis here? So I'm going to shortcut this, but these are kind of symptoms suggestive of an underlying Lewy body dementia, which is actually probably more common than we typically think about. Um, and there are behavioral disturbances associated with it, namely hallucinations. It's going to be pretty common in Lewy body dementia to have behavioral disturbance. The visual hallucinations are actually a core feature of it. Um, so whenever you're hearing someone with visual hallucinations, we should be thinking about Lewy body dementia. So this is a diagnosis, and this is important because it does kind of guide what potential treatments from a pharmacological point of view we may explore, but also what we might want to avoid as well. So the nurses approach you, start asking, hey, well, he's calling out at night, he's disturbing other people, he's not sleeping well. We need some regular medication to address this. So what do you do, right? It's probably a common situation, not just for Lewy body dementia, but any resident basically in long-term care who's not sleeping. There's going to be often a question about medication. So interventions for BPSD. Um, in general, we want to try non-pharmacological interventions first, right? And then pharmacological options really come second. And this is just a reminder. Sometimes it's quite obvious that the non-pharmacological interventions aren't going to work, but still think about it first. Because oftentimes there can be small things that we miss or that's not really included when we get report on a patient that could be helpful in resolving the situation without medications. And if we are going to consider whether it's non-pharmacological or pharmacological options, we want to think about how we're going to address the issue immediately, depending on the urgency, and what's going to be the long-term management, as they can be quite different, and the risks associated, namely side effects, can be quite different. So if we're going to be using psychotropic medications in dementia, there's a few things that I think about. The first thing is we want to be treating whatever underlying disorder there is with first line agents that are evidence based. So I'm talking about if someone has an underlying major depressive disorder or let's say generalized anxiety disorder, there are guidelines out there that dictate what's the best medication to use, what's first line. They even have often sections in these guidelines specifying what medications in older adults to be used. So, there's lots of literature around what to use in MDD, GAD, bipolar disorder, schizophrenia, even for, certain types of dementia like Alzheimer's or mixed Alzheimer's, where we can use cholinesterase inhibitors. We want to make sure that we're optimizing management of the underlying disorder. Um, the reason why this is important is because obviously if they have underlying psychiatric disorder and we can treat that well, the behaviors may improve because we're actually providing appropriate treatment. In BPSD, we talked about there's lots of different types of behaviors, and then we have medications, right? It can seem like, well, this behavior is not responding to non-pharmacological approaches, well, therefore we must use medication. I think, it may be tempting to jump to that conclusion, but it's also helpful to remember that some behaviors just don't really respond to medications, aside from like being sedated, right? So things that we see don't respond to medication and we know really don't respond to medication are things like wandering, hoarding, calling out for no reason, if they're just undressing or voiding in inappropriate areas, or if they're repetitively doing something. We understand the underlying cause of it is related to cognition, cognitive impairment, or neurodegenerative decline. But adding, antidepressants or antipsychotics, they typically won't resolve these behaviors unless they're driven by, let's say, an underlying psychiatric process like, psychosis. Um, the symptoms that do respond are usually kind of akin to some sort of psychiatric disorder that may have existed in earlier life, but is now just presenting for the first time later in life while someone has dementia. So these are things like someone's now presenting with anxiety, or they are clearly now entering into a depressive state. They're not sleeping, if they're developing new delusions, hallucinations, if they're physically aggressive, if they're sexually inappropriate behavior. These symptoms, there is evidence that medications can help resolve them. It doesn't necessarily mean it's the first thing we do, but these are reasons why a medication could be considered. And often, antipsychotics are going to come up as an option. So just a quick refresher about antipsychotics, because I think it's helpful to understand what we're dealing with here when we're talking about these medications, and potentially why antipsychotics out of all the psychotropic medications are kind of singled out in a way as being, part of these initiatives. So the way I like to separate it is in your first generation, also known as typical antipsychotics, and your second generation or your atypical antipsychotics. So the mechanism of action for your typical antipsychotics, it's mainly around dopamine antagonism, so that D2 blockade. And we've got, lots of examples. Most common that we'll see being used in long-term care are things like haloperidol, loxapine, methyltrimeprazine, which is Nazanan. You may also hear zeuclopentixol being used once in a while. Those last few ones are more like older antipsychotics. You'll see them being given in depot for people with, schizophrenia. They're still very effective, but I would say they're almost never used in dementia care. The reasons why One of the reasons why we still use typical antipsychotics a lot is because they come in many different routes. Obviously, they can be given orally, but they can also be given parenterally, so subcutaneously in IM formulations and long-acting depots. The the second generation antipsychotics, the main difference is that there is more serotonin activity, serotonin antagonism, and this is why it's theorized that they have a bit more mood stabilizing effect or even an antidepressant effect, independent of other medications. The most common ones that we'll probably see being used in long-term care are things like risperidone, olanzapine, quetiapine, and maybe now aripiprazole, brexpiprazole. These medications typically only come in a oral format, aside from paliperidone and aripiprazole, which come in depot format. So why do we use the different types of antipsychotics? So the first generations, they're pretty much exclusively used for schizophrenia and related psychotic disorders, whereas second generation antipsychotics are also used first line for bipolar mania, bipolar depression, and is also first line adjunctive treatment in major depressive disorder and OCD. So you can see there's a few other newer indications for atypical antipsychotics. These are probably based on guidelines that are about 10 years old, and they still remain recommended. Um, the side effects, this is really what we care about as geriatric psychiatrists. The main difference is that you're going to have more extrapyramidal symptoms with the typical antipsychotics. So you can get more Parkinsonism, you've got more risk of dystonias, whereas in the second generation, you get less risk of that. With some of the antipsychotics, some of the atypicals still have higher risk. And the other major difference is that you're going to have a higher risk of metabolic syndrome with the atypical antipsychotics. Um, with all antipsychotics, whether it's first generation or second generation, you still have the risk of sedation with certain drugs. Certain drugs can prolong QTC. They generally all lower the seizure threshold, and some of them can cause orthostatic hypotension. So, these are those like drug-specific side effects, antipsychotic ones. Obviously, these become more problematic as people get older, when they're on multiple medications, when they have less reserve to withstand, sedation or orthostatic hypotension. So we talked about like the indications for antipsychotics. We also know there's lots of off-label use, right? We see it being used for anxiety, not infrequently, things like quetiapine being used for just agitation. Let's say if you have a patient in the emergency room or using antipsychotics, we see it being used in delirium for sleep disturbance or hallucinations. And we know that even though it's off-label, we use antipsychotics a lot for various symptoms that we include in BPSD. So similar to thinking about, whether uh, the behavior is responsive to any medication, when we're thinking about antipsychotics, we want to think about, is this behavior responsive to antipsychotics specifically, right? Obviously, all the ones that aren't responsive are still not going to be responsive, but things like depression, anxiety, you know, oftentimes antipsychotics aren't the first choice if they're going to be used for those type of symptoms, and they may not even be effective. Things like delusions, hallucinations, aggression, sexually inappropriate behavior, and sleep disturbance, they can be more responsive, right? So definitely, and if we are going to be using antipsychotics, primarily we want to be using them for delusions, hallucinations, or basically refractory aggression. The sleep disturbance, it's not so much that the dopamine blockade helps us sleep, but it's usually the antihistamine effects. So it's a bit of a side effect taking advantage of the sedation. It's questionable whether this is a good reason to use it, but obviously, it can help. So if we're being posed with a situation where we're starting to consider antipsychotics, we want to kind of make sure we're going through a bit of a checklist before we actually start them. First thing we want to think about, have we tried alternative therapies and are we sure that they're ineffective? Is there an actual risk of harm to the resident or other people, right? A common situation where we'll get is someone, let's say, is having a bit of a delusion. Oh, someone is stealing my stuff. They're not that fussed about it. They kind of mention it here and there, but they're not really acting on it either. And, by the book, yeah, it's a delusion. But if it's not really causing any harm, are we actually benefiting the resident or the patient by introducing an antipsychotic, or are we just exposing them to more potential side effect? And kind of associate with this, even if there may not be a direct harm to themselves or other, are they actually having suffering or distress, right? Which, in a way is kind of like an emotional harm. And this is helpful to think about because it can be a bit of a reflexive to just jump to starting antipsychotics. And I find that this framework is also helpful uh, to be certain that antipsychotics may be the right choice. And it's really helpful to explain it to families as well. So if we're going to start antipsychotics, I try to think about it. What's the short-term strategy and what's the long-term strategy, right? Um, Especially if this is purely dementia related, it's not due to some other psychiatric disorder. Um, so the short-term strategy should be a brief trial, and when I say brief, a 3 to 6 month trial, and we want to be reviewing the efficacy and potential side effects of that medication on a regular basis. So start off once a week, maybe for a couple weeks, then every 2 weeks, every 4 weeks. And when you're starting it, there should also be this goal to taper off. Think about what's the end state strategy, right? So maybe in 6 months we want to try tapering it off and build evidence for ourselves to not taper it off versus trying to demonstrate evidence that we should taper it off. Um, and this kind of helps put a bit closer eyes on the behavior, put closer eyes on the patient, put closer eyes on potential side effects. Because, we know that the literature says that people can actually be deprescribed after 3 to 6 months, and the rates aren't 100% obviously, but there's a good percentage of people that can be successfully tapered off antipsychotics. If you guys are working in long-term care, there's been a lot to talk about antipsychotics, and probably more recently, there's been this discussion, or I think has already been implemented around consent, right? Getting consent for starting what we call chemical restraints. So just a brief kind of refresher around consent. When we're talking about consent, we're talking about valid consent, and that requires the individual to be informed, voluntary, and capable of decision making. And if we find the person to be capable, then that consent comes from the individual. And if we find the person to be incapable, usually if they're not able to understand or appreciate or provide sufficient reasoning for the decision, then the consent will come from an SDM who, could refuse or agree, right? So, I mean, we're not always thinking about it explicitly. I mean, I think with this new policy, there's a bit more, explicit, or there's more expectation for this kind of this written down consent. However, it's usually thought about initiating antipsychotics, right? Because of some of the risks that we may be imposing. But I think it's also important to think about getting consent around stopping treatment, especially if someone's been stable, especially in this kind of with this initiative going around where it's saying, hey, we really want to start deprescribing, families should be on board because there can be situations where someone's actually doing quite well, even though on paper it looks like it's inappropriate, is the right thing to deprescribe. I think it's helpful to have the family kind of on board with that or being aware of what's happening. I'll give a bit of a example of how I do consent. This is something I frequently do in acute care as well as in long-term care. So number one, first thing I do is I describe the diagnosis and behavior. So inform them, they may have dementia, and this is, let's say calling out, and explain what we've tried from an intervention perspective and what has been the result of that. I then talk about the suggested medication. So I'll tell you, say, hey, we're going to start, let's say, risperidone. It's an antipsychotic. I also find it's helpful to inform them what the medication is usually used for, because inevitably the family's gonna read about it anyway, and this sort of like clears, makes it clear what the medication really is and doesn't feel like they're being misled. I want to talk about the specific benefit that we're trying to get for the patient, and as well as the potential risks. So these are common risks, serious risks, short-term, long-term risks. It's also helpful just to lay out what's the plan. How are we going to monitor it? What else are we going to do non-pharmacologically? State that there is a plan to taper things off eventually if things are stable for a while. And the last thing is to provide some opportunity of questions. So I'll use our case example to illustrate this consent process. So you talk to Mr. Lee. Due to his degree of dementia, we find that he's not capable. He can't understand or appreciate his medical situation. So the decision making is now passed to his daughter, who may provide consent. So what I would tell her is, I think your father has Lewy body dementia and is having frightening hallucinations. We've tried reassuring him at night, but he remains quite scared and is still yelling out. He may benefit from a short trial of quetiapine while we also start donepezil. And if you look it up, quetiapine is an antipsychotic medication that's used for the treatment of schizophrenia and bipolar disorder. However, quetiapine can also be used to reduce visual hallucinations in patients with Lewy body dementia. The main risks are that it can cause sedation, falls, tremor, or rigidity, and there's a 1% increase risk of all-cause mortality and stroke in patients with dementia. And what I would say is that, however, given his level of distress, we think the benefits outweigh the risks. We plan to use the lowest dose possible. We monitor his response. We'll continue the non-pharmacological strategies and really try to taper it off in hopes that he responds to donepezil. And I ask her if she has any questions. So this is kind of the standard spiel I give. It kind of covers most of the common questions that I would receive, and it usually won't take too long. And I think with the expectation now of doing this consent every 3 months, it's helpful to have like a very structured framework so you're not kind of reinventing the wheel with every single discussion. It also helps for documentation purposes. Okay, so this next section, we're going to talk a bit about policy and quality improvement around appropriate use of antipsychotics in long-term care. So the BC Ministry of Health, every year they publish something called the service plan. I'm not sure how many of you guys read this. It's a decently long document, and basically it is what the ministry's key objectives are for the year. It includes things like cancer care, ambulance services, mental health services, and for each kind of objective, they have different performance measures. So reducing potentially inappropriate antipsychotics in long-term care has been a part of the service plan for, I think 6 years now, since 2019. So it's been a fairly consistent priority for them. And each year they release certain target percentages as a goal for the province. And this data is collected in each province. And BC in 2023 to 2024, its rates of potentially inappropriate use of antipsychotics in long-term care was 29%, basically, which is above the national average. This data is from CI. So you can see here's BC at 29, and then Alberta and Ontario below the average, national average, and you've got, the rest of the provinces essentially above. 29%, to me, it seems like fairly high. And, working with Health Quality BC over the past year, we know that certain homes are much, much higher, 70%, 80%. Some homes are much, much, much lower, 10%, single digits even. But as a whole, the province is at 29%. So the data aspect is actually really important because it's not as straightforward as we think. So the data is collected by the Canadian Institute for Health Information. We call it CI. And in long-term care, the data is collected through this tool that's developed by Interri. They have different versions of it. Basically, it's an inventory of all this information about this long-term care resident, It's not just around antipsychotics, but it's got a whole bunch of different information. But there are certain sections where antipsychotics and mental health issues and behaviors are collected. So the important thing is to know briefly is that the data they get are only from the full assessments that are completed, so the RI assessments. So uh, the completion rates in long-term care homes are not 100%. Some of them are not even 50%. So, whatever data a home is presenting is only based on whatever they've assessed, and it could be leaving out a lot of information. The other thing to keep in mind is that this data for antipsychotic use is only for residents who have been in long-term care for more than 92 days, for more than 3 months, essentially. So if someone comes into from acute on an antipsychotic and they get stopped, they wouldn't be falling into this data set. And how they establish whether someone is on an antipsychotic is whether in the week before their assessment, have they received antipsychotic for 1 or more days, right? So this would obviously include regular medications that are given daily, but it could also include PRN medications if they're being utilized. Now, obviously, we can think of off the top of our head potentially appropriate uses of antipsychotics, and this is what Kai has listed as appropriate use of antipsychotics, which would fall under their exclusion criteria in the sense that it doesn't get included in the data set either. So these are patients that are at the end stage, have what they consider end stage disease, palliative, or getting hospice care. If they have a diagnosis of schizophrenia specifically, if they have Huntington's chorea, or if they've experienced hallucinations or delusions within the past 7 days. So if you meet any of these criteria, in a way, Kai is saying this is appropriate use of an antipsychotic and would not be included in the statistics. I mean, obviously, as a psychiatrist, certain things stand out. I feel like there are disorders, which I've listed before, where antipsychotics are first line treatments or first line adjunctive treatments. Yet, under the criteria, they would be considered inappropriate. So these are things like schizoaffective disorder, bipolar disorder, adjunct treatment for MDD, OCD, or treating psychosis and dementia, right? They're kind of like first line treatments as well. Um, it seems like a miss, but realistically, the patients or the individuals that have these diagnoses, they really make up a very small percentage of people in long-term care. It's about 1%, right? So the majority of patients that are receiving antipsychotics under the inappropriate criteria are patients with dementia. Nonetheless, it does sound like the CHI are going to be updating their criteria to add these disorders to the exclusion criteria. Um, at the end of last year, there was also an update to the Ministry of Health, Home and Community Care policy, and you may have seen some of the, um, you know, policy within your long-term care home change quite suddenly, or more attention being placed suddenly because of this policy change. And they basically updated the policy of chemical restraint use. And there was notable increased pressure on reducing rates from administration quite kind of abruptly. And the biggest thing they introduced was this need for uh, getting new consent every 3 months if there is what they quote inappropriate antipsychotic use. So usually getting the family to consent every 3 months. Um, we've had some um, meetings around this with family doctors and gotten feedback as well as from psychiatrists and even non-physicians. And obviously there's been this kind of perception this is largely administrative burden. So I think there is being some discussion from a ministry level about revisiting this frequency, um, because there's lots of arguments as to saying, is this really helpful for the person or not? Nationally, there's quite a few different organizations looking at antipsychotic use, and they kind of all lumped together to create something called the Appropriate Use Coalition. And in June of this year, they've announced this new target, 15%, um, with a goal of 15% relative annual reduction. So obviously that's quite far from BC's rate of 29% right now. But that's sort of what's been announced. So it'll be interesting to see how that rate gets, whether it gets adopted by the different ministries on a provincial level. So some of the quality improvement initiatives that exist around Canada right now, we've got Health Excellence Canada, Choosing Wise in Canada, and then in BC we have Health Quality BC, which April had talked about before. So, obviously we know antipsychotic use, if it's inappropriate, I think a lot of us can see, this happening and we recognize it. Um, but it's still obviously quite high. So what are some of the challenges that we noticed, right? COVID, definitely there was an increase in rates during and after COVID. Um, we know that nursing workload is definitely correlated with rates of antipsychotic use. We're starting to see a change in the population that is living in long-term care now, namely starting to see more younger patients with more acquired brain injuries, patients with more underlying mental health diagnoses. If you work in an urban center, I'm sure this is anywhere you actually work, there's been a greater pressure for discharging patients from acute to long-term care who may not necessarily be fully stable. And then the last thing that we has been told to us in different kind of focus groups is there's always been a big challenge in engaging physicians to participate in the process. And it's an interesting question, interesting issue, and we had done some surveys. We talked to different physicians who work in long-term care to get an idea of what are certain barriers or reasons why they may not engage. And it really comes down to two things, I think. It's the time that we have, especially if you're the family physician working long-term care, it's the time that you have. And there's also an element of moral distress, right? Especially for someone that is already on an antipsychotic and is, stable, quote unquote, or if someone is really highly behaviorally aggressive, what do we do, right? So it's always like you're kind of weighing this, like, okay, are we gonna disturb the status quo? Are we gonna try to remove a medication that probably has been helpful, and now introduce this risk of them getting worse or risk of hurting someone else? We're weighing that with, a potential improvement in quality of life, potential long-term risk reduction, right? And this is always a bit of a gamble, and I think that's why there's always some hesitance, because we obviously put a lot of value in making sure someone, at least cross-sectionally, is doing quite well. Um, so some of the thoughts that we had in around how do we engage physicians in this process? How do we do a better job of this? Well, can we make the process easier? Can we improve the confidence in the physicians or prescribers that the chance of them successfully prescribing is going to be better? And can we allocate resources more efficiently so that the deprescribing process is not solely on the physician? How do we make it more of a team effort? Obviously, these are big questions. We don't have the full solutions, but these are some things that we're working towards in these different quality improvement initiatives. There's a algorithm that exists out there. It's from deprescribing.org. It's kind of a national organization of things mainly led by pharmacists. And this is kind of how they propose to approach deprescribing. It's usually based on like the current guidelines, and including different exclusion criteria and how to like taper the medication. Um, to me, it's like I've read through it. It's right. It's a bit daunting to use, though. For each patient, if you've got multiple patients on antipsychotics, you're being asked to prescribe. Running through this algorithm can be a bit um, cognitively heavy. So one of the things that I was trying to think about during my fellowship was how do we make this process easier, and what's really the concept behind this? To me, I tried to think about, well, is it just appropriate or inappropriate? I think there's actually a bit more gray there. In my mind, there's clearly appropriate use of antipsychotics. There's possibly appropriate, there's possibly inappropriate, and clearly inappropriate, right? And this is a balance of like, is the medication indicated, and is it actually effective, or is it causing us problems, right? So if something is really helpful and effective, the likelihood of us just deprescribing that successfully is probably pretty low. Versus if someone is on an antipsychotic and it's really not indicated at all and it's not really working, we've got a much better chance of deprescribing, obviously, right? Um, so this is kind of like this is a table that I kind of had brainstormed myself to think about, well, what do I think about when I'm thinking about what's clearly appropriate or what's clearly inappropriate? I'm not going to go through the details of this, but essentially, if you've got a clear psychiatric disorder and you're tolerating the medications, it seems to be quite appropriate. If you've got, let's say, BPSD symptoms that are not responsive to antipsychotics, like wandering, then the medication is probably only just sedating the person or causing them to be immobile. Um, you know, maybe it's not really even doing the job. So the chance of us being able to deprescribe with no change in their behavior is probably higher. So what I developed was a an app essentially that incorporates all that decision making and only requires the user to input what they know is clinically happening, right? And we kind of publish this under this website aualtc.ca. I'm gonna see if I can demo it with the case that we had. You guys can also try it for yourselves. Here we go. Okay, so this is the website. You can, yeah, like I said, you guys can try it on your own. So, for example, we'll use Mr. Lee as an example. So we said that he had Lewy body dementia. So you can click it or say Lewy body dementia. Um, and the medication that we were proposing was quetiapine. Okay. And some of the factors that Kahai looks at, was he receiving end-of-life care? No. Did we try non-pharmacological approaches? Yes. We don't think he's experiencing side effects yet. And is he being followed by a mental health team? No. And what was the behavior? We're seeing he was having visual hallucinations, and that's it, right? Um, we generate assessment, and basically the assessment says it's possibly appropriate use. We want to make sure that we're optimizing non-pharmacological approaches, because we know in Lewy body dementia, antipsychotics can help, but we also know that cholinesterase inhibitors can also help with hallucinations. And the recommendation is that we continue the current antipsychotic, recess it in 3 months. You want to make sure we're optimizing non-pharmacological approaches, and we want to monitor if there is recurrence of the symptoms after they're stable, and if the behavior persists, you might want to consider referral to a geriatric psychiatrist. So it's supposed to be as user-friendly as possible. You can copy and paste diagnoses in here. You can copy and paste the medication list. It will kind of search through whatever text you put in there, and hopefully it gives you a recommendation that's useful. So yeah, we're like constantly trying to get feedback on it, looking for any rooms for improvement. If you guys find mistakes, we've hopefully tested it thoroughly enough. But it's just something that my hope was to make the process more efficient. So you're not thinking about what the algorithm is saying exactly. You're just saying, okay, what do I know about the patient and what should we do? Okay, I'm gonna go back to the screen. Um, okay, I think that's the end of the main talk. I know we've got a good amount of time now for questions and answers, and so if you guys have any topics that or questions specifically or things that you want me to expand upon, we also have some like previous questions that were asked in the past. We can also go over those. Let me see. So you guys can just put the questions into the chat, and I can always read them.
There's a couple so far, Bryan, in there.
Okay. Um, let's see here. Okay, here we go. What is the data? So this is from William Cunningham. What is the data informed medically indicated correct percentage? Is it competition between provinces to the bottom? Oh, I see. Yeah. What is the medically centered medically correct? Yeah. Okay, gotcha. I think I understand it. In the meetings that we've been at, the Kai High is quite clear that they're not aiming for zero, right? Because they realize, there's going to be a percentage of patients who are going to be classified as inappropriate that we really know antipsychotics are the only solution to the problem. So I don't think there's a question about, getting down to zero. Um, to know what is the right percentage, that's a really tricky one. We know, you can think of maybe the long-term care home you work in, or if you work in multiple long-term care homes, which I do, we know that the population, even though we think it's generally the same, we know there's differences, right? Like, for example, I work at one care home that has only single rooms, so they become they become the most common destination for people coming out of tertiary older adult mental health. So these are patients that are refractory behaviors due to dementia. So, inevitably the percentage of that home is going to be much higher than the other care home I work at. Um, they do have some statistical models where they can adjust for patient population, taking in those clinical factors to come up with, what's the adjusted rate. Um, you know, it's a really hard question to answer. I think one thing that we've talked at Health Quality BC is to try to think less about the percentage, right? Because percentage can be really misleading. We know there's lots of ways to game the system around percentage, around how you code patients and stuff like that. What we try to focus on is having successful deprescribing events, right? So, in this next year, if you can deprescribe, on two patients, that's actually going to reduce, that's going to be the main goal you want to look at. So just pick two patients and try to see if we can get the antipsychotic off. Like, find the patient that you think has the best chance of doing this and try to deprescribe. And it's one of the ways it's like helps build confidence because you can successfully do it. And it helps you get into practice as a cared home around deprescribing. And if the focus becomes around trying to do as many successful deprescribing attempts, the percentage will naturally come down. I know administratively there's lots of focus on the percentage, however. So I agree. Trying to make it patient centered is really probably the most important thing, and the statistics don't necessarily do that. Just a comment from Teresa about lack of recreation, activity, diversion, and engagement. Yeah, it's really tough, with resource limitations. We know recreational therapists, recreational workers, music therapists make a big difference for the whole population as well as those with, let's say behavioral disturbance. Ralph Jones, really get to know your resident. My colleague had a resident with frontal lobe dementia who was quite unmanageable, especially at meals. And the discovery was a junior Canadian ski champion and showed a GoPro loop of meals of a point of view downhill ski lift. These are exactly, this is a great example of utilizing that sort of like pieces approach and understanding what was their life story, right? We know that especially activities or things that someone enjoyed in their younger years can really spark a lot of joy and be a great, activity, not just a distraction, but a great activity for the person to engage in. So I think that's a great example. Margaret kind of expressed a similar thing about getting to know your residents better. Uh, Rick asked, do you use benzodiazepines in Lewy body dementia? Um, there are certain reasons why we do. This is namely for REM sleep behavior disorder. So this is if someone's asleep and they're calling out or they're moving a lot, and basically it's causing a lot of problems. Either they're waking up everyone in the room in the care center, or they're like constantly falling out of bed or injuring themselves. If the literature shows that melatonin is first line just because it's got less side effects, but second line, but more effective is clonazepam. So those would be the times where we're using benzodiazepines. Outside of REM sleep behavior, we're not routinely using benzodiazepines for things like hallucinations, delusions. We try not to use it because they're really not going to be helpful. John Chan, persistent screaming patient night and day. What can be done if avoiding? What more can be done if avoiding all antipsychotics? Um, yeah, the calling out, persistent calling, it's a really challenging symptom because of, it's not really harming anyone physically, but the disturbance can be quite dramatic. And people end up in tertiary older adult mental health for this reason, just for really refractory calling out. So it's definitely a significant symptom. The approach that I would actually take to this is thinking about, again, from a PC's point of view, what what are the needs? Obviously, we've exhausted that. Is there an underlying psychiatric disorder, right? Do they seem, and you're at this point, you've tried the kind of standard things. You're trying to do your best guess to understand what's going on. Is this related to them being scared, right? Are they actually hallucinating? So those are reasons why you may try antipsychotic. What happens in tertiary mental health usually is once we've exhausted everything and it's still quite problematic, you'll see us turning towards antidepressants because it's almost like a presumed anxiety or depressive disorder, and we try antidepressants. So, in fact, if this was just refractory calling out, we would actually turn to antidepressants versus antipsychotics. In the end, it's still quite challenging. If it's refractory, oftentimes I would say, recommend, if available, getting a geriatric psychiatrist to do an assessment can be quite helpful. Um, yeah. Um, oh, is there a separate section for Q&A? Okay, I'm reading it now. Huh, I'm not familiar with this Zoom. Okay. Vitamin Q. Uh, Quetiapine is used very frequently. It counts in your antipsychotic sense. Low doses acts as a expensive Benadryl. What's your opinion over use of quetiapine? Um, I think, we use quetiapine as psychiatrists frequently because I think it's like you said, it's more sedating, it's got a calming effect, and it's got a lower risk of EPS. But in the same sense, it doesn't save you from those longer term stroke and mortality risks. And it does have a bit of a more anticholinergic effect. So, if we were in a situation where we had to choose to use antipsychotic for purely sedation reasons, it's probably a better choice than using something like risperidone or olanzapine. Um, I think we are probably overusing it in long-term care, and I would say that you can probably apply the same approach, and I would not think about it as like a safer antipsychotic. Yeah, clozapine. Use it pretty frequently, virtually no EPS used in Lewy body, but yeah. Yeah, I think clozapine's a special one. So in my algorithm, I say if someone's on clozapine, it's like it's almost likely it's going to be appropriate. At least in most long-term care or in most places I work, clozapine isn't just being started for run-of-the-mill, agitation. It's usually gone through a bit more of a diagnostic process. And, Ralph, you're correct. In Lewy body dementia, Parkinson's dementia, it is considered basically gold standard treatment for psychosis. But at that point, usually people have been on a trial of quetiapine before, just because you don't have to have the blood work. Um, I would say if you're thinking about other behaviors, I would probably stay away from clozapine just because it has just so many other risks associated with agranulocytosis, myocarditis, seizure risk. The risk benefit profile really needs to be established for that. Does the degree of aggressiveness prior to settling with antipsychotics affect your decision to deprescribe? Yeah, I think it would, right? I think it definitely would. We were trying to do our best to guess what's going to happen after we deprescribe. And we only have the information historically to guide that decision, really, right? So it doesn't mean we don't deprescribe, not necessarily, but we might want to put more mitigating factors in, such as closer monitoring, making sure there's PRNs, making sure that all staff and family are aware that this is happening so that we've got close eyes on it. Um, and, obviously for more severe, aggression or violence, there may be a decision where it might not be appropriate to be done. And I think the rationale that you explain or you put down is probably going to be important. Lane, we've had a number of residents with advanced dementia that for one reason or another strike out during care leading to physical injuries, WC staff absences, rather than to snow them in antipsychotics. There's been a trend to midazolam PRN use. What are your thoughts? I mean, we group this kind of like resistance to care, aggression during care. It's a really, again, really tricky situation because it's in a lot of the cases, it's very isolated, right? And it's almost understandable. If you're a patient with dementia and you see someone that you don't recognize trying to help you with care that you don't think you need, um, you can understand why the natural response would be to like, get away or protect themselves. Um, there are different non-pharmacological options that people have tried. There was a study that I was involved in using basically video of a family member during care, pre-recorded video. So there's different things to think about. Music has been used. Um, so I would say, as much as it doesn't seem part of your typical arsenal of tools in home care, it's helpful to try to at least try them. Um, this is a case where, if medications have to be used, this is really a good situation to think about what are we really trying to achieve with the medication, right? Because if we're just trying to achieve sedation, right, then we want to be sure that we're using a medication that is as purely sedating as possible without extra effects, right? So you'll definitely see like in tertiary older adult mental health, you'll see benzodiazepines, shorter acting ones, midazolam, lorazepam being used at times, but you'll still often see things like quetiapine or methyltrimiprazine being used. Again, it's a situation where you're trying to exhaust every other option, and there's the whole talk you can talk about addressing resistance to care, but obviously with resources are limited, it can be quite challenging. Okay, I'm gonna jump. Oh, there's more. Okay, trazodone is used a lot, but not always helpful. Thoughts about pregabalin for agitation. Um, Yeah, trazodone obviously is used a lot because it is kind of a sedating medication, fairly quick acting, not too many side effects outside of the sedation, maybe orthostatic hypotension. But again, I agree, not always helpful. Pregabalin, um, I don't see it being used that often. I would say it's not part of our typical selection of medications. It's very related to gabapentin, obviously. I personally, I don't find it that effective. It's not really listed as in the guidelines. There's recent literature that shows that pregabalin's got a higher, I think it increases the risk of like heart failure. Um, treatment would be probably down the line, even probably below a benzodiazepine. Um, okay.
Just going back
I'm
to
gonna
the
catch up.
chat, Brian, I'll try
Yeah,
and help you
yeah,
out a little bit because I know
yeah.
that there's you've been
No,
going
I can
back
see,
and
I can see
forth.
now. So Brenda Wilson, yeah.
Yeah,
We need
so
an
that's
alternative to
amazing.
antipsychotic medications that actually help with agitation. Okay, so a similar question. Yeah, everyone is. It kind of goes down this. We want a medication. Obviously, there's lots of demand because it's something reliable, something we can anticipate, something we can use in all situations. Um, this is we gave a similar talk at another session, and it often became around what medications do we have available, and I think it's related obviously to appropriate use of medications or antipsychotics. Um, I would say again, the non-pharmacological stuff, especially if behaviors are refractory, can be really helpful. There are lists of medications that have more evidence in, let's say, agitation specifically. Things like nabalone is actually fairly evidence-based, and side effect profile is a bit more favorable. Smith, do you recommend such residents be transferred to a behavioral unit? Residents with dementia and borderline aggression without physical incidents. Nurses keep saying potential for aggression. Will the transfer make things worse for these residents and lead to more medication or being added or changing environment? Okay, yeah, it's a really good question. I think this is a situation that really depends on what resources are available to you in your community. So in Vancouver, where I work, we've got general population long-term cares. We have some care homes that have special care units, which is I'm guessing kind of similar to a behavioral unit. And then you've got like I think we have two places that we call it special care plus and special care plus plus, and then we have tertiary mental health. Um, what I would say is, it's again, it's really understanding the individual and is this truly dementia related behavior? And if it does turn out this is purely dementia related behavior where safety is becoming a concern and the medications that your guys are comfortable using in the long-term care doesn't work or they need closer psychiatric follow-up, the recommendation around special care units often is made. The challenge is when will they get transferred to the special care unit? For example, I have a patient right now in one of my long-term care centers who, it's very clear they need a special care unit. They're exit seeking. They get easily agitated because of their cognition. They think they work there. No sort of medication is going to help reverse that. Um, and they've been waiting for a special care unit for like 6 months. So in a way, we've become the special care unit. But I think it not referring them to the special care unit is probably less helpful because we want to be indicating that there's a need for this and that we're trying to make like the best recommendation or best intervention for them. And if it's not available, then that's that's the reality. But I don't think we want to be not making those referrals. Would you have any pharmacological and non-pharmacological suggestions for resistance to care? Yeah, I think this was kind of addressed in another question. I have one resident only allowed 3 baths in 2 months. I really find this common currently. Yeah, the bathing one is, I mean, it's kind of interesting as well. You know, one thing that certain homes I've worked in, they find alternative ways to bathe that may be less invasive. I know sometimes residents really, if they get lifted, they don't really like that part of it because it's kind of scary. So thinking about, are there alternative ways to get the care done can sometimes be helpful. Um, would there be an initiative in the future to prescribe antipsychotics from acute prior to move into LTC? It's a great question. There is actually one that we're applying for a funding in Vancouver right now, in North Vancouver, to address this topic specifically. So the transfer from acute to long-term care, because I'm sure you guys are familiar with the situation. Someone is admitted to hospital for whatever illness, pneumonia, they're delirious, they recover, and it turns out they need long-term care and there's sundowning, and the doctors in acute start them on regular loxapine or quetiapine, and they don't get deprescribed, and they show up, and now you're like, okay, well, it was started by a psychiatrist. Should I touch it? Um, so I think it's a to me and to our team, it's a really good opportunity to try to make some change to make it a bit easier um, for long-term care doctors. So we're working on it. Hopefully, we get funded. But I think regardless, even for myself, who has always had a kind of mindset around deprescribing, just being part of this project has made me probably deprescribe even a bit more in acute. I do lots of consult liaison work, so I think just thinking about it and spreading the word helps reduce it. Nablone can be effective for anxiety. Yeah. Yeah, I kind of talked about Nablone. There's quite a lot of evidence, and maybe I'll be a bit more specific about it, especially if you're concerned about antipsychotic side effects. So for cases like Lewy body or Parkinson's, or someone that has a history of becoming Parkinsonized on antipsychotics, Nablone can be a good option. I think one of the things that a lot of the people in this antipsychotic use, that are involved in this, they're thinking about, okay, well, sure, we're starting to deprescribe antipsychotics, but are we seeing the rates of other medications go up? And inevitably we are. So I think, in certain situations, it does make sense. Do you want to see, 29% of people in long-term care on Nabalone? Hopefully not. Yeah. Um, Highland. Okay, yeah, Margaret. You guys are ahead of us. That's great. Um, when when do you turn to Abilify use in Vega or in Vega for non-occupied? Okay, yeah. So aripiprazole. Um, you know, Personally, I don't use aripiprazole that much in BPSD. Mainly because um it's not like that great of an antipsychotic, in the sense that if someone truly has psychosis, we tend not to see it work as well as something like risperidone. And in patients with Parkinson's or Lewy body, it's still more Parkinsonizing than quetiapine and clozapine. So its kind of role is kind of fuzzy for me. the most of the time I'm using aripiprazole actually is for adjunct treatment of depression. So in addition to a antidepressant. So I mean, it's interesting though because there's been new literature around brexpiprazole, which is kind of like a sister medication to aripiprazole, about its use in what they classify this new diagnosis, agitation in Alzheimer's disease. Um, I think I'm cautious. Again, I don't have any stakes in this, and I'd say I'd be this is a fairly new guidelines. I'd be cautious around using it. I would say again, think about what do we think is going on from a symptom perspective? What do we think is the psychiatric correlate, and how do we best address it? And aripiprazole typically doesn't come up into discussion for me very frequently. Either we're trying to treat the psychosis, or we're just trying to provide sedation, right? And aripiprazole doesn't really help with either in my mind. It can be used. There's very specific uses, like if someone does have an underlying psychiatric disorder, then it's a whole different situation. In Vega, which is paliperidone injection for non-compliant clients. Um, we we typically, again, this is just for dementia care. If someone is on risperidone or paliperidone, we try to avoid using long-acting injections. The main reason is obviously long-acting, so it's really hard to get out of their system for whatever reason. And as people get older, they become more susceptible to things like EPS, drug interactions, and we really want that ability to adjust, right? So if someone is really non-compliant, we really have to be certain that this is really the right medication for them from a dementia perspective. The times where I do see it being used, if someone has typically a more mild dementia with associated BPSD like psychosis, and essentially it's less akin to dementia care, and it's more similar to treating a psychotic disorder, right? Like I have this patient recently who had to go to hospital because they've got this long-standing, this kind of recurrent delusion. They never were what we call certifiable, and eventually they were. And he refuses to take medication. He refuses to live in his long-term care facility, and it was clearly driven by a psychosis. And in that situation, because he was still mobile and quite functional, even though we thought the psychosis was clearly due to a dementia, a depot injection was started. If it's for a person with more severe dementia and they just aren't compliant with medications, I think, and we're trying to treat, let's say, agitation, I think there probably needs to be more discussion and more thought about whether injection is the best choice. Um, okay, those are really, really good questions.
Fantastic
These are some of
question.
the situations that we as psychiatrists, geriatric psychiatrists, we struggle. We put a lot of thought into, and oftentimes when things aren't clear, when they're often not clear, it's going to the family or going to the SDM and really going in as detail about the risk and benefits and what we anticipate is going to be the future outcomes, so that they can be most informed and making sure that this is really keeping them within someone's goals of care. Because in a way, some of this treatment can be considered palliative, right? If someone is so agitated and they're requiring to be sedated, then is this really the right quality of life? So we kind of think about what's the priority here. Okay. Um, any other questions right now? The Q&A. Is there more? Um, I think that's all.
Great to see the work happening in Ireland as well around the acute side of things. So, well, I'm sure we will be in touch with you, Margaret, around this. It's definitely been, it always comes on our radar, and we've been pulling some data as well. So,
Okay, I'll kind of I guess we'll close it off. I guess these are some of the questions that I had received in a previous session, but I think you guys covered most of them. So, yeah, the last thing about tapering, maybe this is from the Canadian Coalition for Seniors Mental Health, and this is a kind of if the decision is to prescribe, it's pretty simple, and what they recommend is decrease the dose by 25 to 50% every 1 to 2 weeks, and then monitor. And then just to close off, just want to thank Chelsea and Andrea, who are part of our team. They're not here with us, and as well as Colin. Um, think I'll give you guys back a few minutes of your night.
Wonderful. Thank you so much for a wonderful presentation. We really appreciate you guys taking the time to chat to us today.
All right. Thanks for
Thanks
having us.
everybody for joining.
Thanks, everyone. Have a wonderful evening.